Latin America is a vast and diverse region extending from the Rio Grande River on the northern border of Mexico to the southern tip of Chile. The Andes Mountains, which exert a decisive influence on the climate of South America and constitute the geographic focus of political activity and economic development, cut across all the countries on the continent. Clinging to the sides of the mountains and perched atop high Andean plateaus are ancient cities and modern capitals. As a region, Latin America is rich in natural resources, including petroleum and other minerals, forest lands, fertile soils, and abundant sources of water. Although Latin America has only 8% of the world's population, it possesses 23% of its potentially arable land, 23% of its forest land, 31% of its usable surface water, and 19.5% of its hydroelectric potential. Latin America is the most heavily forested region in the world, with timber covering 48% of the total land area. The region also possesses the largest river and the most arid desert in the world. This environmental diversity has generated tremendous genetic diversity, which constitutes another valuable resource, but one which is still largely untapped. Only 9% of the region's potentially arable land is currently being farmed, and 21% of the energy consumed is generated hydroelectrically. By the late 1970s, researchers had examined the chemical makeup of only 1% of the 50,000 plant species found in the Brazilian Amazon. The population of the Americas, which in 1950 was around 331 million, is expected to swell to over 1 billion by the year 2025. The average rate of urban growth currently exceeds 68%. Living conditions in the major urban centers of the region have deteriorated markedly in recent decades. In addition to heavy concentration of industry and population pressure on the environment, there are huge discrepancies between social groups. A large portion of the urban population consists of people who have recently emigrated from rural environments and small communities. Rapid urbanization, depletion of natural resources, and technological change are affecting health directly and indirectly. In the Americas, diarrheal diseases are among the leading causes of death in the population under 1 year of age. These diseases are the result of consumption of contaminated water, deficient environmental and household sanitation, and poor hygiene and eating habits. The waterborne diseases present in Latin America and the Caribbean include Shigellosis, viral gastroenteritis, typhoid fever, hepatitis, and cholera. The most recent example of a classic outbreak of waterborne disease in Latin America is the cholera epidemic that began in Peru in January 1991 and eventually spread throughout Central and South America. The earliest cases caused by Vibrio cholerae 01, El Torinaba, were identified in Chancay, close to Lima, Peru. Several days later, more cases were reported from various communities located along the 1,200-kilometer coastline north of Lima. After that, the epidemic spread rapidly, peaking in late March 1991 at 20,000 cases per week. By the end of the year, every department in the country had been affected. The epidemic produced more than 320,000 cases and some 120,000 hospitalizations during 1991, placing a heavy burden on Peru's already overtaxed health services. The second country to be struck by the epidemic was Ecuador. The disease was apparently introduced by fishermen who had fished off the coast close to Peru. The number of cases increased rapidly, reaching its peak in April 1991. The incidence then declined, but the disease continued to spread to mountainous and coastal areas along the principal land and water routes. As had occurred in Peru, the number of cases began to rise again during the last quarter of 1991, reaching an all-time high in March 1992. after which it declined markedly. The most severely affected area in 1992 was Guayaquil, the principal coastal city, which accounted for 1/3 of all cases reported in Ecuador that year. Colombia was also hit by cholera in March 1991. The disease first appeared in the southern Pacific coastal region. From there, it spread slowly inland and along the coast, eventually affecting the entire country. The incidence remained high in Colombia throughout 1992, and then dropped 98% in 1993. Brazil reported its first cases in April 1991. Cholera was introduced via the Amazon River and tributaries from Peru and Colombia. The disease was confined to this area for several weeks, but later began to spread eastward along the Amazon. By the last quarter of 1991, it had become a full-scale epidemic and reached the city of Belém on the Atlantic coast at the end of the year. In 1992, the epidemic spread to most of the northern regions of the country and produced more than 30,000 cases. In 1993, the incidence of cholera rose 66%, and the disease extended into most of the southern regions of the country. While the spread of cholera throughout South America was expected, the appearance of cases in a small community in central Mexico in June 1991 was a surprise. The disease is believed to have entered Mexico as a consequence of illegal drug trafficking activity. Health officials were unable to stem the infection, which spread to a large portion of the country. Particularly high rates were registered in southern Mexico along the coast of the Gulf of Mexico and in the states bordering Guatemala. Outbreaks continued to occur in 1992, and the highest number of cases was reported in August, and the disease continued to show the same seasonal pattern and geographic distribution, with outbreaks in Mexico City and other major cities. Guatemala and El Salvador experienced serious epidemics in mid-1992, which coincided with the season in which diarrheal diseases are normally most common. In Guatemala, the number of cases climbed steadily during the second half of 1993, eventually totaling 99% more than in 1992. El Salvador had relatively small outbreaks during the first half of 1993, but in December of that year, a major outbreak occurred, causing 2,000 cases a week. This increase was apparently linked to travel by the population during the Christmas holidays. The largest number of cases occurred in San Salvador. The impoverished slum areas around the city were hardest hit. Panama, especially the province of Darien, was severely affected in 1992 and registered the third highest rate in the Americas that year. The rate increased again, more than doubling, in 1992. In 1993, however, it fell 99%. The first cases in Nicaragua were detected in November 1991, but the incidence remained low until April 1992, when a large-scale epidemic spread throughout the southern and western portions of the country. In 1993, cholera spread into the more remote central and Atlantic regions, and the number of cases was 111% higher than in 1992. During the second half of 1993, Honduras experienced a large increase in numbers of cases compared to previous years. Costa Rica, on the other hand, saw a decline in cases in 1992 and 1993. Bolivia, although it shares a long border with Peru, had no cases until August 1991, 7 months after the first cases had been reported in Peru. The infection remained confined to the area around La Paz until February 1992, when it began to spread to the tropical lowland regions, bringing the total number of cases that year to over 22,000. The disease spread to Argentina and then to Paraguay, and it continued to occur on an epidemic scale in southern Bolivia and northern Argentina in 1993. At the same time, cholera continued spreading along the Atlantic coast of South America, striking Venezuela, French Guiana, Guyana, and Suriname. Happily, however, Venezuela, Guyana, and French Guiana had fewer cases in 1993 than in 1992, and Suriname reported no cases in 1993. Population movements were the principal route of cholera transmission from one country to the next. Investigations of cholera deaths and their association with the population's access to and use of health services have revealed that most deaths occurred in cases in which the cholera victim either failed to seek medical care or waited too long to go to a health service. Among such individuals, the fatality rate was close to 50%. Although overall cholera fatality rates were low, the figures varied considerably among countries. In remote and hard-to-reach areas, the rates were 10 to 20% higher than in capital cities, where the population has access to the best hospitals. This was a matter of great concern in Nicaragua, which saw its fatality rate rise to 5% in mid-1993 as the disease spread to remote populations and areas affected by the civil conflict in that country. In Latin America, as in other regions, cholera is almost exclusively a disease of the poor who lack access to safe drinking water. In some of the large cities of Peru, consumption of unboiled water from municipal sources was a major risk factor, and the fact that contaminated water was being supplied by extremely deteriorated systems undoubtedly contributed to the rapid and extensive spread of cholera. Even in Peru, those who had the resources soon learned to decontaminate their water or found sources of safe drinking water, and cholera thus became a disease of those who lacked sufficient means or knowledge. In all the countries, another important source of infection was food, which became contaminated with the cholera microorganism through improper food handling, preparation, and storage practices. In some countries, a causal relationship was shown between cholera and the consumption of insufficiently cooked shellfish, which had been caught in contaminated waters. Throughout Latin America and the Caribbean, wastewater is often discharged without treatment into rivers, lakes, and oceans. It is frequently used to irrigate crops, especially vegetables, which require large amounts of water and fertilizer. The risk of contamination of these foods is obvious, although no link between this practice and transmission of cholera has been conclusively demonstrated. By late 1991, cholera had been reported in 15 countries and had spread from Mexico to Chile and from the Pacific coast in Peru to the Atlantic coast in Brazil. 5 more countries were struck by cholera in 1992. Uruguay was the only country in Latin America that remained free of the disease during the period between 1991 and 1993. To date, none of the Caribbean island countries and territories have detected any cases, but all have maintained intense surveillance. In all the affected countries, cholera occurred most frequently among adults. More than 75% of the cases were detected in persons over the age of 5. Although with other diarrheal diseases, 75% of the cases are generally found in children under 5. Peru set the general pattern for cholera in the Americas. It accounted for 82% of all the cases reported in 1991 and 60% in 1992, but only 36% in 1993. The Americas as a whole accounted for 67% of all cases reported worldwide between 1991 and 1993, the years in which the greatest numbers of cases have been reported during the 7th cholera pandemic. In 1993, the regional fatality rate rose to 1.8%, which may have been due to several factors, including underreporting of cases among survivors, the existence of the disease in hard-to-reach areas, and improper treatment of cases. Nevertheless, the figure of 8,622 deaths attributed to cholera during the 36 months of the epidemic can be considered relatively low compared to the estimated 150,000 child deaths that occur every year. Between 1991 and 1993, healthcare establishments in the Americas treated more than 941,000 cases of cholera, more than half of which required hospitalization. This caseload placed a severe burden on the health services. Conservative estimates indicate that at least 100,000 lives were saved through proper treatment. The later rise in case fatality rates observed in Bolivia, Panama, and Nicaragua prompted renewed concern for correct treatment of cases. In some countries, more cases were reported among males than females, but it is not known whether this was because more males were exposed to the disease or because males were more inclined to seek treatment. During the 3-year period between 1991 and 1993, the countries of the region and the Pan American Health Organization mounted an emergency response to the cholera epidemic. An intense effort was made to establish surveillance systems or improve existing ones, and to disseminate information on the epidemic and the correct way of managing cases in order to prevent deaths and complications. Special emphasis was placed on the supply and use of oral rehydration solution. All the countries took steps to improve the capacity of their laboratories to confirm the diagnosis of cases, determine the antibiotic susceptibility of the microorganism, and detect Vibrios in food and water. In thousands of communities, methods were developed and implemented for disinfecting water, disposing of human waste, and handling foods in order to prevent contamination. Prevention activities relied heavily on social communication and health education strategies. In order to put the emergency measures into effect, PAHO mobilized more than $21 million from the international community. These measures reduced the incidence of cholera in several countries, while simultaneously contributing to a reduction of Salmonella typhi infections in Chile and helping to decrease the frequency of diarrheal diseases other than cholera in Costa Rica, Nicaragua, Mexico, and several other countries. It remains to be seen whether cholera will eventually strike the Caribbean islands, causing large epidemics in the poor areas of the major cities. Some island nations, such as Haiti and the Dominican Republic, would appear to be just as vulnerable to the disease as their mainland neighbors. The Caribbean has been readying itself to fight cholera for more than 2 years. No one knows whether the region will succeed in eluding the disease, and no one can predict to what extent the Caribbean might be affected by an epidemic. In Peru, Ecuador, and several Central American countries, present cholera rates indicate that the disease may have become endemic. It is therefore essential to continue prevention activities and to maintain ongoing surveillance of epidemiological, bacteriological, and antibiotic resistance patterns until it is possible to correct the existing deficiencies in health services and environmental sanitation.